Yeah, so two great pieces of data presented recently and is going to be presented, I think, at upcoming meetings too. The first, as you talked about, is the AVONELLE-X long-term extension trial. So what is this study? This was basically 2 years of additional treatment with faricimab for patients that were in the original parent studies, which was the Tenaya and Lucerne study. These were studies looking at the treatment of either aflibercept or faricimab for patients with neovascular AMD. So in the first 2 years of the study, they could have received either aflibercept every 8 weeks or faricimab in basically a treat and extend fashion. And then if they rolled over into the extension, all the patients in the extension, so for the next 2 years, so years 3 and 4, received faricimab in a treat and extend fashion. And so a couple things, before we get into the data, a couple things is that this was the largest long-term extension for neovascular AMD of its type. So this was really kind of a lot of good phase 3 data essentially that we were collecting. And there was a high retention rate. So the people that finished the Tenaya and Lucerne study, over almost 90% of them decided to roll into the AVONELLE-X study, which I think says a lot about the treatment and the patient's confidence in the treatment. And that was reassuring. And so, any of these studies that we see, we wanted to see the most retention, the highest retention possible, because that's going to give us the strongest data. So, what did we see? We saw from a vision standpoint, the vision remains very stable through years 3 and 4. In the real world, we see over and over again data sets that show us that there's just a precipitous vision decline in years 2, 3, 4, and beyond in patients, especially neovascular AMD patients. And a lot of that is because I think we probably undertreat our patients, not because we choose to, but life happens. Patients get lost; they have difficulty coming back in, and so what we're hoping for with newer treatments that are more durable is that you can give these treatments less often, but not sacrifice vision outcomes. And I think that's kind of what you're seeing in this study like this. In years 3 and 4, so in those last 2 years, patients received a median number of injections of 7 injections, which was great to see. The other piece of data I thought that was really good coming out of this extension is that when patients were at 20/40 vision or better at year 1, when you treat these patients and you fast forward now to the end of year 4, 75% of those patients maintain 20/40 or better vision, which is incredible because, that's something that you can immediately kind of translate to how we talk to our patients that come in, newly diagnosed wet AMD patient. They're nervous, they're worried that they're going to lose vision. So the question then is, doc, am I going to be able to drive, 3 years from now, 4 years from now? And with this type of data, we can tell them, look, if we do what we need to do and we treat you, there's a good chance we can keep you driving and keep you independent. That's vision. And then from an anatomy standpoint, we see kind of those really incredible improvements that we saw in CST in those first 2 years of Tenaya and Lucerne. We saw that those were maintained in years 3 and 4 when all patients were on faricimab treat and extend. We saw that about 80% of patients were on an extended 12-week or longer dosing interval at year 3 and 4, with 65% of patients getting to 16-week dosing intervals. And then if you took that treat and extend criteria and you applied it to these patients, you would actually see that 51 to 53% of patients could actually achieve a Q20-week dosing interval. So again, we're starting to see new treatments that are more durable, and with many of our patients getting to 12, 16, and potentially 20-week intervals in this case. The other piece of data that we looked at was what happened to those patients that were on aflibercept at the end of year 2, so at the end of Tenaya and Lucerne, that had persistent retinal fluid. So they could have had persistent intraretinal, subretinal, or both types of fluid at the end of year 2, because then all those patients are switched to faricimab. So the question is, were those patients that had persistent fluid, did they actually improve when they were switched? And indeed, we saw a significant number of those patients improve. So at the end of the 2-year study, the patients that had aflibercept, there were 152 patients that still had persistent retinal fluid. At year 3, so now these patients have had a year of faricimab treat and extend. We saw a 27% reduction in the number of those patients that had persistent retinal fluid. And by the end of year 4, we saw a 44% reduction in the patients that had persistent retinal fluid. So potentially, the question is, why would these patients that were treated pretty aggressively with aflibercept but had still persistent fluid, why would they benefit from this switch? And, one theory is that it's the dual mechanism of action. Now we're not just, hitting them with an anti-VEGF, but we're addressing the Ang2 pathway as well. So that's kind of the thought process with that. Safety, these extension trials are very important because they give us good safety data. And we saw that faricimab was well tolerated and all the safety signals were in line with what we saw in the parent phase 3 study. So just kind of concluding that this was a really nice, the largest of its kind long-term extension study. We had patients in this trial that had faricimab for up to 4 years, with good disease control, which actually improved over time. We saw great anatomic benefits in patients that switched from aflibercept to faricimab, and then we saw that it was well tolerated, good safety data as well. So that's the AVONELLE-X data. SALWEEN, slightly different patient population. So for SALWEEN, we were looking at PCV patients, and PCV patients receiving faricimab. And so at a high level, I think what's really important to highlight from this data, so we're kind of done with year one of the data was presented. We saw really good outcomes. PCV is kind of traditionally more difficult to treat and control and get resolution in disease, than maybe kind of typical or standard neovascular AMD. And what we saw in this patient population was these patients did very well, in terms of disease control, in terms of vision outcomes. And what we saw was quite a few, the majority of patients were actually able to get out to Q24-week dosing intervals, which is, something that we're really starting to see in terms of pushing the interval extension on these patients. And so there's still a lot more data to come out of that. This was kind of this top line data presentation, but again, reassuring that patients did well, really on par with what we historically had seen with, doing a PDT treatment, for example. So here we see really good control, disease control at the level of that type of treatment, but really good vision outcomes in addition. And so, again, with minimal treatment, with extended treatment intervals. So that's kind of the two studies, and exciting data that came out of some of the recent meetings. Yeah, I think if you look at it, if we treat kind of like what this protocol treated as, which is very similar to how we treat in the real world, treat and extend. I think if you treat patients in a treat and extend fashion, you can expect to get pretty good durability. Now, these were, for the most part, treatment naive patients. It's always a little bit tricky in the real world because now we're throwing in patients that are a little more complicated, right? A lot of them are switch patients. A lot of them are patients with disease that may not have been included in these types of trials, whether it's inclusion exclusion trial issues. So it's always a little bit tricky that where it doesn't translate necessarily one to one. But I also think you're seeing in the real world some real world data sets that are kind of mirroring this extended dosing, and so I do think that what we're seeing in these phase 3 studies and then the extension and then in the real world all kind of put together indicate that these treatments are more durable than potentially what the older treatments were. Yeah, yeah, like, so I think a couple things. I think first and foremost, no cases of occlusive vasculitis, right? I think anytime in this day and age when we have a new treatment, we want to make sure it's safe because we have really good treatments already, right? So if we're going to incorporate a new treatment, not only from an efficacy standpoint, durability standpoint, we want this to be better than what we're using, but it has to come without any kind of exchange in safety profile. Like we need this to be safe because that's what we've grown accustomed to and that's what we expect. And so I would say everything we saw in years 3 and 4 was in line with what we saw in years 1 and 2 of Tenaya and Lucerne, which was basically showing that faricimab was as safe as the comparator, which was in this case aflibercept, which again we have used for over a decade, and have grown very comfortable with in terms of safety. Yeah, I think, there's always this question of, should we save these, you know, quote unquote better treatments or stronger treatments for later in the disease process. And I think I see that in terms of some barriers that we see, not just in the US but across the world. And the issue then is, I think you're better off, and I think there's data that's come out recently that shows if you can control the disease earlier, you're more likely to get better outcomes at the end of the day. And that could be, depending on what your outcome of choice is, but look, vision is very, very important. anatomy, so anatomic control, CST improvements are important, but also durability, right? So if we can get disease control early, which you're more likely to do with better agents, then I think you're able to get better outcomes in the end. Here I show you in year 4, we still have good stable vision versus what we've seen historically where vision kind of falls off the cliff. And I think it's because we treat these patients appropriately, aggressively in the beginning, and that's what gives us those outcomes in the end. So if we talk about just barriers, I think it's getting access to these treatments early on in the disease process. I think that's a universal issue that we see today. And those are the things that hopefully we can address and help, whether it's regulatory bodies or payers understand that it is really important to treat people appropriately from day one. Yeah. So, it's always nice when you have a treatment, a first line treatment, for example, that can be widely applied, right? We want to be able to use this treatment or a treatment, and it being able to help multiple groups of patients. And so I think what Salween shows us is that what used to be a tougher patient population, what used to be where we would have to kind of pick stronger agents, things like that, I think you can use faricimab confidently and feel like you're gonna get the best result for a patient using that medicine. Yeah, I think when you get, anatomic control of these polyps, you're gonna get, basically quiescent disease, so fluid resolution, which is gonna translate ultimately to vision, right? At the end of the day, that's what matters most to us, that's what matters most certainly to the patient, and so when we can, quote, unquote, "shut down" these polyps or these PCV lesions, you're gonna get better outcomes, and you're gonna be able to do it without the need for frequent injections, which is oftentimes what we see today with kind of the first generation anti-VEGF agents. Yeah, we talked about neovascular AMD, PCV, which are kind of on the same spectrum, but we didn't talk about our diabetic patients. Our diabetic patients really benefit. And recently, Ronex extension data was presented, which showed kind of similar results, which is really nice results anatomically speaking, from a vision standpoint, and again, from a durability standpoint. So, again, I think our diabetics really benefit. We know that they have this kind of global vascular disease. You've seen some of these fluorescein angiograms with almost like what looks like vasculitis because there's diffuse edema. And so for those patients, this dual mechanism of action really makes a lot of sense, because you're not just addressing the VEGF issues that these eyes have oftentimes, but also these Ang2 issues that they have.